Good morning or good afternoon, everyone, depending on where you are located. I am really excited to chat with you guys. Hopefully, everyone has had a chance to join previously, but just a reminder or quick overview for anyone who hasn't been able to attend our previous 4 weeks of these sessions. They are all available or will be available soon on our YouTube channel. So please take a look at that. And I believe someone can put it in the chat if needed. But we have already reviewed just kind of a broad overview of ARFID 101, as well as a deep dive into each of the three recognized subtypes. So today, what we're really going to be focusing in on is what a lot of people come into this treatment experience or come into the experience of recognizing that someone that they love has ARFID, and that's how do I support my loved one? I get questions about this all the time, and it can feel really confusing. You can feel really helpless. You can feel really stuck and scared. There's so many emotions that come into factor in and come in to influence people when they find out that their loved one has an eating disorder. And with the diagnosis of ARFID, there are far fewer resources than there are for a lot of our other eating disorder diagnoses. And so, what I want to talk about really specifically today is what some of those strategies are. And hopefully, you can walk away from this with a few tools, and then we'll have plenty of time for questions at the end today. Unfortunately, my co-host Jennifer Vedito wasn't able to make it. She's traveling today. She did contribute some dietary stuff to this slide, so she should be on next week. So if anyone has nutrition specific questions, it may be worth holding them until next week. I can always do my best, but she's a far better resource to answer those sorts of things than I am. So there's I've broken this down into 6 sort of broad categories or types of things that y'all can do to support your loved ones in treatment. And a lot of them are things that can be done completely separately from interacting with your loved one. I know many of y'all have loved ones who are in a higher level of care, and that's what brought you into this conversation today. And so if you have a loved one who's in inpatient or residential treatment, you're probably just getting a phone call with them for 45 minutes once a day, or maybe you do get to see them in person once a day or a few times a week. And that's pretty limited interaction compared to them living full-time at home or being able to call and talk whenever you want to. So I wanted to make sure to have a good blend of what are some things you can do when you're interacting with your loved one, as well as some things that you can do sort of independently of interactions with your loved one. So we're going to start first with providing emotional support and accountability. And I think this is where, when we think about how to support our loved ones, this is where people's minds tend to go first. Like, what can I do to support them in the moment? How can I support them when they're in a challenging exposure? How can I support them when they give me a call and they're in a lot of distress? So the number one tool that I recommend that people use, and this is some therapy language, some a little bit jargony, but really it's validation. It's one of the most effective, useful skills that can be used honestly in almost any situation. It can be used with someone who has a mental health diagnosis, who's in treatment. It can be used for your neighbor. It can be used for the cashier at the grocery store. It really is kind of a one size fits all tool. There is a little bit of a learning curve to it, and kind of the basics of it are pretty straightforward. And I think anybody has the ability to use it. So when we're validating, we're acknowledging that someone else's emotions and experiences are real and important. It doesn't mean that we share those experiences or emotions. It doesn't mean that we agree with them. It really is more about practicing empathy, putting ourselves in their shoes, and imagining what it's like to be them. What must they feel in this situation with the things that are going on in their life, that are going on inside them, going on in that situation? How must they be feeling? What are some things they might be thinking? And acknowledging that even if you do that, they might still be having a different experience, but we're practicing what it's like, almost as though we're actors and we're trying to pretend what it must be like to be someone else. You sort of do exercises kind of like that to really put yourself in their shoes and understand where they might be coming from. And again, we don't have to understand it to really imagine what it must be like to feel that way. So one example I like to kind of have an analogy for this is if you have never lost a close loved one, you've never had someone in your life who's close to you pass away, you don't have to have gone through that experience to imagine what it must be like to go through that experience. If you've never lost a parent or a sibling or a close relative or a close friend, most of us can still put ourselves in that position of, oh, how difficult must that be? How sad must they be? How angry might they be? How lost and depressed might they feel in that situation? What must that grief experience feel like? And so, even if you haven't been there, you can imagine that that would be really difficult. So, we don't have to know exactly what our loved ones with ARFID are experiencing. We can watch them go through that distress and also imagine our own selves being in there. And so then we're going to follow, do this practice of empathy and then put some words to it. It makes sense why you would feel scared. It makes sense why you would feel frustrated. It makes sense why you would feel, insert the name of the emotion that they might be experiencing in that sentence. For anyone who's familiar with emotion focused family therapy or EFFT, if you have been in the ERC system, hopefully you've learned this already. But we love to follow this up with because and what are some reasons why you imagine they might feel that way. That's kind of like next level of validation. I think just starting with a basic, I can understand why this would make you feel anxious, or I can understand why you're really scared right now. I think just simply acknowledging that their emotion is real and valid and important can really go such a long way. And kind of imagining like if you've ever been angry and in an argument with someone and then they kind of recognize how you might feel or like show that they can understand where you're coming from, it kind of just sort of takes the wind out of your sails a little bit in a positive way. Like people tend to feel less angry. So the goal is not to take the emotion away. It's really to help carry the load of that emotion with them. And by acknowledging that their emotion is real, their distress is real, that it's important to you to understand that it's real and that it's there and impacting them goes so far. Um, Sort of beyond that, one of the things that our patients tend to experience is this lack of confidence in themselves or a lack of self-efficacy, a sense that they are capable of accomplishing certain things or completing a task. They tend to have a hard time moving towards some of those more challenging things, in part because a lot of them have been stuck in these cycles of avoidance for so long, or they're so scared or worried about what it might be like to actually go towards some of these foods or scary experiences. And so you guys, as their support system, many of y'all have long-standing, if not lifelong, relationships with your loved ones in treatment. So you've probably seen them go through some hard things in their past before and seen times when they've persevered through those hard things. So reminding them of that can be really powerful. Sharing with them and expressing with them your confidence that they can do it can also be really powerful too. I know you can do hard things. I believe in you. Reminding them that you're right there with them. I'm right here with you. I know you can do this, even though it's hard, and I'm going to be here with you, cheering you along, or I'm going to be here with you to support you. I can't do it for you, but I'm going to be right here and doing everything I can to help you. Um, Sometimes just knowing that someone is in your corner really is so helpful. And just that encouragement and kind of sort of that cheerleading that can happen when someone's going through a tough time in treatment. Another thing that comes up for a lot of our ARFID patients, one way that ARFID patients tend to be a little bit different than some other eating disorders is that, in my experience at least, there's a higher portion of them that really don't want their eating disorder. They actively want to get rid of it. A lot of them do choose treatment and seek out support on their own, which is something that's a little bit less common in some of our other, what we call egosyntonic eating disorders like anorexia or bulimia, where it can kind of feel like part of their identity or something that feels so scary to give up. They kind of want to have it. There's some sort of like social reinforcement for having it. With ARFID, that a lot of times isn't present in quite the same way. And so if your loved one is someone who said, hey, I want help, I want this to get better, I'm choosing treatment for my eating disorder, I don't want to live this way anymore, I want to change things about my eating and my relationship with food, then sometimes they go into treatment and it gets really hard and it's harder to remember all of those reasons and connect with them again. So you guys are a great resource to be able to remind them of that. Like, remember when you were deciding to come to treatment and you were so fed up with this thing about your eating disorder? Or remember how scary it was at the doctor's office when you found out that you had these nutritional deficiencies and you really wanted to work on this so that you could be physically healthy? Remember when you were in the hospital and you weren't able to eat any food and you were on a feeding tube and you were medically unstable and your heart rate was low? That was so scary for you and you really wanted to not be in that position again. Like, remember how treatment is going to be helping you with that. So it's kind of that reminder of like the big picture why that sometimes can get sort of lost when you're having that anxiety or that fear that's right there in front of you. Um, and a lot of our patients, whether or not they actively chose to come to treatment or they sort of felt pushed by their family, or maybe it's a child and you're their parent and you made them go to treatment, many of them do have things they want to accomplish. And it might be different from like what the family or the treatment team wants, but they have things they want to get out of it. So maybe they want to be able to eat at a restaurant. Maybe they want to go to a birthday party with their friends or a sleepover or some kind of school event. Maybe they want to eat lunch with their friends at school and not get weird looks because they're eating something strange or they're not eating lunch at all. Um, so again, like that reminder of what those goals are and connecting the work that they're doing in treatment to those big picture goals. The treatment team does this too, but a lot of times it can feel different coming from the support system that knows them and loves them and is going to be there after treatment's over. It might help to point out reason or ways that ARFID gets in their life, gets in the way of them living a normal life, gets in the way of them doing the things that they want to do, or causes them so much distress. Like, wouldn't it be nice to be able to go to a restaurant and eat off the menu, not worry about what they have offered on the menu, because you have enough options where no matter where you go, you can order something off the menu. They're always going to have something that you can tolerate or you're able to eat. So again, just helping them see the big picture. That distress really happens most of the time or a lot of the time when they're focusing on the short-term challenges and what feels hard right in that moment versus the long-term outcomes of how treatment can be beneficial or how doing these exposures can be beneficial. Speaking of exposures, one of the very most important things that you guys can do is hold your loved ones accountable for completing exposures and do not let them avoid. I get the question, how in the world do I do that? Like, I know that they need to do this. I paid attention when you taught me the cycle of avoidance. I understand why. They might understand why they're still avoiding, and I can't force them to watch a video of someone vomiting. I can't force them to eat peas. I can't force them to eat 6 times a day instead of 2 times a day. Um, so sometimes it's just that extra accountability, especially if your loved one is at like a PHP or lower level of care and you're spending several hours a day with them, even if it's just in the mornings and evenings. Reminding them of that exposure plan and having that accountability can be really helpful. Sometimes that avoidance is strong when no one else is there to remind them about it. But when they do have that reminder, it's kind of like, okay, like if I'm going to avoid this, it now comes with a little bit of guilt instead of just me knowing that I avoided it. Um, Again, reminding them of why exposures are helpful, how it's going to feel hard temporarily, and then it's going to feel better later on. Um, the validation comes in handy here too, validating that the exposures are challenging. If they weren't challenging, it wouldn't be an exposure. That the intent to some extent is to cause distress. We know that it's going to create anxiety or distress, and that that's useful. There's a purpose to it. But don't over validate. Like that's one area where I will say, like, if you validate too much when it comes to exposure, sometimes that feeds into the avoidance. So, when we're talking about kids or potentially even young adults who are still living at home at like transition age youth, kind of college age kids, um, you can set limits related to exposure completion. So a lot of our patients at ERC have what's called a home phase system. So they have their phase system within programming that then transitions into home. And for each phase, there's different privileges. So the higher phase you are, the more privileges you have, which helps to create some external incentives when people are really struggling with that internal motivation and drive to do things on their own in treatment. If it was that easy just to do it on your own, then most of our patients wouldn't have landed in treatment. So having that external motivation. So it may be like, hey, you can only have phone time on your phone if you're at phase 2. And if you're not even trying your exposures, you won't be able to get to phase 2. So reminding them of that kind of stuff. I don't feel comfortable with you having the keys to the car if you're not completing exposures and you're not meeting your meal plan goals. You might not be medically safe to be driving. And I really want to make sure that you're working hard on your treatment. And then even more importantly, beyond that, is to collaborate with your loved one and the treatment team to build in a reward system to incentivize exposures. Hopefully, this has already been done. It's sort of part of the exposure and response prevention protocol that have rewards built in. But if that's not present or the rewards aren't effective, we definitely want to take a look at, maybe you complete every time you complete an exposure, you earn some screen time, or we are going to go buy tickets to see a movie, or we're going to go shopping and you can pick out one item to buy or order something off Amazon. There's all different things that you can do. But that would be something to talk to your team about if it's not currently on board. Um, Along with this comes meal coaching. So, meal coaching is a skill that is taught. It's not something that comes intuitively to most of us. So I want to make sure Jennifer and I both wanted to make sure that you guys came away from these talks with some specific tips around meal coaching. So first, you're going to want to practice a low pressure approach during meals. So you want the environment to be calm. If you're feeling anxious and worked up, it's important that you're doing something to calm yourself down and manage your own distress ahead of time. Watch your body language. A lot of times our patients are really sensitive to people watching them eat. So if you're sort of hovering in really close or making a whole lot of eye contact and just kind of staring at them really intensely, that's going to create a lot of anxiety. Like if you're out in public and you feel someone staring at you, it's sort of like that, but then you're also doing a really challenging, high pressure, potentially anxiety provoking act while someone's staring at you. And that really just doesn't end well most of the time. You, of course, have to watch your loved one if you're responsible for monitoring their intake, but really try to do it in a way that's not just directly staring at them the whole time. Um, Again, using those relaxation skills yourself to bring down the anxiety, do it with your loved one if that's something that's part of their plan for managing anxiety around meals too. And then when you're starting to eat with them, providing those prompts like, hey, are you willing to try a bite of your peas right now? Remember, we're working on eating lots of different types of foods. We're trying to practice eating different types of foods. Can you take a bite of your sandwich altogether? Can you take a bite of your sandwich that has the meat on it? Taking a bite with them, like, hey, let's take a bite together, 3, 2, 1, or hey, that was a great job with the first bite. Let's see how you feel after one more bite. So really kind of doing it as light as you can, but also in an encouraging way. Again, doing it with them. I think if you're eating a similar food, taking bites with them for a lot of our patients, that can be really helpful and supportive. Um, Back to validation, validate when those foods are scary or they are feeling overwhelmed with the sensory properties of food. I know you haven't had it before and that can feel really scary. Let's try a little bite to see what it feels like. Go back to that 5-step process that we've talked about a couple of different times. Okay, like, hey, this is your first time trying a sandwich with meat on it. Let's take a look at it and let's, tell me what you see, tell me what you feel, tell me what you smell, and then we'll take a tiny bite together and see what you think about it. If it's a food that they've tried before, remember for our loved ones who have sensory sensitivity subtype, you might be doing up to 30 or 40 exposures of a food before they're able to incorporate it into their diet. So there's going to be times where they try food, they don't like it, and then they're expected to keep trying it. So when that happens, reminding them, hey, last time it didn't taste good. And sometimes new taste can be sort of overwhelming. It might taste really strong. Let's see if it tastes the same. Sometimes it tastes different when we've tried it once or twice, and then we try it a second or third time. We definitely don't want to assume that we know how it tastes for them. Our taste buds are all different as individuals, and something that tastes this comes up a lot for me with my kids, and I know this happens for a lot of other kids too. I live in Texas. We eat a lot of spicy food. I grew up eating a lot of spicy food. My kids are all very sensitive to spicy food, so I might eat something, think it tastes totally normal and not spicy at all, or just a tiny bit spicy. My kids take a bite of it and all of them are like, oh my gosh, it's so spicy. So I don't ever want to assume with them. I mean, they don't have ARFID, but they definitely are pickier than me and pickier than a lot of other people. So if I'm here assuming like, okay, well, I took a bite of it, so I know it's not spicy, and then I reassure them that, oh, hey, it's not spicy, they take a bite and it is, that breaks down trust that they have with me and also feels kind of invalidating for them. And so I think it's the safest option is just to say something like, I don't know how it's going to taste for you. For me, it tastes this way. I wonder how it will taste for you. Let's take a bite and find out. Um, Most of you guys probably, if you have a loved one with sensory sensitivity or really strong taste preferences, or if they are very worried about vomiting and do tend to have a more sensitive gag reflex, they may gag or potentially actually vomit while eating new foods or while eating in general. So what we want to do if they do have a gag reflex while they're eating, we want to kind of pause and we want to bring down the anxiety as much as possible and try to prevent vomiting where we can and create an environment where they can come back to the eating and start back up. So we want them to keep the food in their mouth, practice taking a few deep breaths through the nose, put their hands on the table or on the arms of their chair or on their lap, somewhere where they're going to feel kind of solid and stable. We want their bodies to feel sort of calm and secure as much as possible. That's going to help their brains calm down as well. Focus on the feeling of the table, breathing while they swallow as much as they can. If they need some water or some kind of beverage to help them swallow the food, um, and then take a few minute break just to practice breathing for a little bit before you go back to trying. The last thing we want to do is they have this really strong gag reflex. They manage to get the food down, and then you rush into taking the next bite and they gag again. And then the more they're gagging, the harder it's going to be to interrupt that. So we want to try to take a break as best as we can to prevent that from happening again. All right, so I want to talk for a minute about expectations in ARFID treatment. I know we've talked a few different times before, but I wanted to kind of bring it together really for all of the subtypes about what are some realistic expectations that we have in treatment. When we talk about treatment outcomes for other eating disorders, anorexia, bulimia, binge eating disorder, the goal is often to return to normative eating without engaging in behaviors, restricting or binging or purging or anything like that. And we want people kind of eating what they used to eat prior to the onset of the eating disorder. That is not always an appropriate or recommended outcome for patients with ARFID for a few different reasons. One thing that I think is important to keep in mind is for all three subtypes of ARFID, or if you have a combination, this would be the case as well. One of our top priorities, sort of beyond like medical stabilization and weight restoration, our top priority is really centered around psychosocial functioning. So if it's helpful for someone's psychosocial functioning to be able to eat a wider variety of foods, that's great. But we don't want to push the variety to the point that it's causing so much distress, or they end up having such a contentious relationship with food, or they're so averse to eating food that it backfires. We're sort of trading one set of problems for another. And so, that's where it becomes really important to look at the goals that that individual has for their life, or goals that we as like healthy adults have for someone who is a child, maybe within reason. We're going to want to look at how can we help them improve in their relationships with other people and their functioning in their day-to-day activities. And then making sure, of course, that their nutritional and medical health are stable as well. But that's really the lens that we're looking at this through. We're not just looking at behavior interruption. We're not just looking at weight restoration. We're not just looking at having someone eat what people might generally consider a normative variety of food or eating in normative ways. We're looking at how can we help them have the most effective and functional life possible without sacrificing kind of their mental health in some ways. So we're looking at supporting that functional improvement primarily. And that's why it's so important to consider your loved one's goals when we're setting these treatment goals and planning exposures. Again, in the absence of, unless it's a very young child, like say 7, 8, 9, and they just don't have kind of the cognitive ability to make these sort of decisions, even if it's someone who's 13 or 14, even like 10, 11, 12, we're going to talk to them about what do you want to be different in your life? What would you like to improve about how you relate to food, how you eat your food? And that those might not be the only goals of treatment, but those are going to be the goals that are driving the course of treatment. It's really not a necessity for patients to eat from every single food category. We want them to meet all of their macronutrient needs. So things like protein and carbohydrates and dietary fats. If they're not eating fruits and vegetables, it's not the end of the world. Ideally, they're eating some fruits and vegetables, but you can also get around that through dietary supplements, through fiber supplements, other things like that, finding ways, foods that are fortified to have some of the nutrients that they might miss out on if they're not eating any fruits or vegetables, or very few. One of the most common things that parents, especially for kiddos or kids and young adults with sensory sensitivity coming in, the parents often are really focused in on, I just want my kid to eat one fruit and one vegetable. And I totally see where that's coming from. And I think if that is a realistic outcome for your child or your loved one, that's fantastic. There are some people that that's just not a realistic outcome for them, and that's okay. We can find workarounds for that if needed. And it's not always worth the distress that comes from really pushing, you just have to be able to eat a green bean, or you have to be able to eat a grape. That the breakdown that happens in the the relationships that they have with you, the distress they go through the process of being able to eat this thing that really is not super additive to their life or improving their functioning, it doesn't feel like a great trade-off in most cases. So that's why it's so important to plan with your loved ones through the course of treatment with the guidance of your treatment team, and looking at how can we balance their medical and nutritional needs with what they want from their lives or what would improve the family's functioning too without damaging or negatively impacting the individual with ARFID. And many people live full and meaningful lives eating the same few foods every single day. So, unless there's someone who just really loves to travel and their travel is so hindered by the fact that they only eat peanut butter and jelly sandwiches every day, we're really going to kind of look at, is it that important for them to have a greatly expanded variety of food from any sense? And if it is, great, like we're going to use treatment to help with that. And I don't want you guys to hear from this like we're not going to try to expand dietary variety. We absolutely do want to do that when it makes sense to, but within limits. And we're not going to push someone to a point that it's no longer beneficial and it could actually be potentially have some negative impacts for them too. Um, Additionally, patients are often going to have a very difficult time completing exposures if they have no interest in eating that food or they don't identify benefit to incorporating that food. So that's where fruits and vegetables get really dicey for us. Like, it can be really challenging to justify, like, hey, we're going to put all this time and energy into you being able to eat a strawberry when realistically, strawberries are not a component found in a lot of different foods. What might be more worth their time is if they're able to conquer cheese, because cheese is on a lot of different foods, or if maybe they eat white bread, but if they could eat pasta too, that opens up so many different options of foods that are available to them if they can have two different sources of carbohydrates versus just one, or multiple protein sources, or maybe they can eat sauces on their food instead of just plain butter noodles. That opens up a wide range of different options of foods they can order at a restaurant, foods that you can make at home, makes eating a little bit more varied and interesting. One of the last things that I want to talk about with relation to all of the realistic expectations is that it is very common for individuals with ARFID to also have some form of to be neurodivergent. Maybe they have ADHD, maybe they're on the autism spectrum, maybe they have learning disorders or some other sensory related, like sensory processing disorder. Things along those lines can need to be factored in when we're looking at how to approach treatment and how to look at long-term outcomes for these individuals. So we don't want to force patients who are neurodivergent to adhere to neurotypical standards. So if there's somebody, like let's say they have ADHD, and ideally what we would love is for them to sit down at the table and have a family dinner all together. But if their ADHD is not well controlled or their ADHD does not allow them to sit and focus in on eating, especially when eating is challenging because of their ARFID, we may have to plan to have, um, you know, TV or music on in the background, or maybe plan to play games at the table, or plan to have shorter meals if they're able to eat their meals in a faster amount of time, or breaking down their meals differently, having different timing throughout the day. It does not have to be standard neurotypical expectations around eating. And really, if we try to force them into, the square pegs into those round holes, it's really doing people a disservice and not factoring in that their brains are structured and wired differently than someone who has the label of being neurotypical. So I think it's really important. Another example of that, throwing back to ADHD, is thinking about the kinds of foods that people might eat. If they have, especially if they have lack of interest subtype, where eating food is really difficult, and then their executive functioning skills just aren't a great match for things like planning out meals, shopping for meals, preparing meals, sitting down to eat at certain times of day. It might be helpful for them to just have a bunch of frozen dinners in their freezer, or to plan to drive through fast food restaurants on their way home from school or work, having prepackaged snacks readily available. There's so many things we can do to lower that burden of what is required through executive functioning to actually eat food 6 times a day and meet all of their dietary needs. So really the way that I want to sum this up is that recovery does not always mean normative eating for people with ARFID. And if you were born with ARFID, if you have one of those subtypes that's long-standing, the chances of you becoming a normative eater are not 100%. And we don't want to force someone into that expectation or really push so hard for that if it's not realistic for them. some educational resources, and you guys will get sent this slide, so feel free to take notes, but also don't feel as if you have to. There are unfortunately not a ton of resources out there, again, because ARFID is a relatively new diagnosis. It's only been a formal one for about 11 years. There is one book that I do really like. It's by Rachel Bryant Waugh. She is a um, British researcher and clinician, and she has this ARFID guide for parents and carers that I think is really great. It's nice and it's small and it's short and it's to the point, but it's really geared towards people who are not professionals and are caring for someone who has ARFID. So I would highly recommend that one, and I think it's pretty cheap on Amazon too. Food chaining is another really great one, especially for if your loved one has sensory sensitivity, some type of ARFID. It kind of talks through, comes at it from a non-ARFID perspective, but it definitely applies to ARFID. Food chaining is a strategy where you take, you're working from one food to another, and you kind of take small gradual steps with foods in between. So for example, if your child or loved one eats chicken nuggets and the goal is to get to like a grilled chicken breast, you might go from a chicken nugget to a chicken tender to a breaded chicken patty to then maybe a small piece of grilled chicken or a chicken that's cut up with maybe something on it to then just a plain grilled chicken breast. So you're kind of chaining the foods together to go from one food to another. Otherwise, it might feel like a big shift and be more difficult to tolerate from a sensory perspective. So there's a lot of great tips and tricks in there. It's one that our dietitians use pretty frequently. The CBT for ARFID manual that really we've kind of pulled from through a lot of this presentation has some really great handouts too. I know the 5-step method is one that I've pulled directly from that and put in the slides in a couple of the different talks that we've given. But I would definitely either purchase that book on your own or talk to your treatment team about getting those handouts. They're the ones that apply to your loved ones because I think they're written in a way that's really easy to understand, but packs a lot of great knowledge into just one page of information. Sad Perfect is actually a novel. It's not strictly an educational resource, but it's a novel about a teenager who has ARFID. I include it just because I think it's helpful from an empathy standpoint and from just kind of building some insight and awareness into what your loved ones might be going through, especially if you do have a loved one who is a child or teenager that might sort of relate to kind of the emotions and social situations that people in that age group might be experiencing. And then I've also listed a bunch of blogs and links to, I think, 1 or 2 podcast episodes through ERC. So I won't go through all of them, but they're ones that different people within ERC have contributed to in terms of the content. There's some for different age groups, some that are just looking at symptoms, kind of broad overviews, different things like that. Okay, one thing that we are often harping on people about when loved ones come into treatment is support for you guys. So your loved ones get a bunch of support from y'all, from the treatment team, from their support system outside of you guys. But you guys are going through this too. While you're not the ones with the eating disorders, you guys are also going through something incredibly difficult. If your loved one had cancer, we would absolutely be expecting you to be receiving support from a lot of different areas. And really, eating disorders are not that different from a loved one going through a cancer diagnosis and treatment. And so I really want to highlight a few ways that sources of support and ways that you guys can support yourselves or receive support from others. So the higher level of care treatment team, if your loved one is in IOP, PHP, residential inpatient treatment, the higher level of care team's primary purpose is to support the patient, your loved one, but they can also provide support and guidance and education for the families and caregivers as well, and referrals for additional resources. So maybe they know, I know here in Dallas, we have a pretty big support or a pretty big referral network for therapists in our area that specialize in supporting families who have a loved one with an eating disorder. Some of them have worked at ERC before, so they have a great understanding of what it's like for you guys to be going through this process. We might have some tools, or maybe we just need a family session to kind of process through what you're experiencing, how that's impacting your loved one, and how we can help you help yourself or help you respond differently to some of those situations that you're put in with your loved one going through treatment. And similar with the outpatient team. So your loved one's outpatient team serves kind of a similar function. You may have less frequent contact with them just because it's a less intensive level of care for your loved one. But you might have a longer standing relationship with them. If your loved one has been seeing their outpatient therapist for 2 years, that's a long period of time that outpatient therapist knows your loved one, knows the family. They have a pretty good sense of what your loved one is like outside of treatment because they're seeing them at an outpatient level of care. So they can be a great resource as well. We have local education. I'm speaking through about ERC in particular, but other treatment centers will sometimes offer things like this, or there may be like local talks that are given by professionals in the community. But I can speak for ERC. Many of our local regions, either individual sites or regionally, will have um, education, like psychoeducation, family education. I know in the South region in Texas, all of our sites have access to our virtual family education series, that anyone who has a patient in Dallas or San Antonio or Houston or Austin or the Woodlands has access to those educations, and they're happening 2 to 3 times a week. So there's a lot of opportunities for learning more about what your loved one might be going through during treatment. Um, we also have national education series that are offered, as well as our caregiver support groups, like the one that Beth Ann runs. So definitely check the ERC website for those kinds of things. I don't believe we have any right now that are ARFID specific, but it can still be really supportive and helpful and validating for you guys as caregivers going through kind of a similar experience to other caregivers who have loved ones who are in treatment right now. There's often local support groups as well. So that's just something you would have to look into a little bit more independently, or use your higher level of care outpatient team as resources to help find local resources for support groups and things like that. Lastly, I do want to mention the social media groups like Facebook groups, subreddits, and things like that. I I say this with caution because it can be really difficult to ensure that the information other people are providing is accurate. You may be interacting with other caregivers who are struggling emotionally themselves, or you may interact with someone who has a loved one who's going through a really scary time, and that can then raise your own anxiety. And that it can be difficult to see and hear and consume all of this information if you're having a hard time yourself. That being said, the social media groups can feel really validating, and it does open up a resource for gaining opinions and perspectives, suggestions, and support that otherwise might not be accessible. So they're definitely not all bad. I think some people have an entirely negative view of these social media support groups. I think, there's pros and cons to everything. I think just use it with caution, use it responsibly, know when to back off, and know when to take things with a grain of salt. And I know that there's been a lot of people who find that really, really validating and supportive. And because ARFID is something that is not talked about that much really in the world, it can be really great to be a part of a community and feel like there's other people that know what you're going through. Let's see. So one of the last things that I want to talk about is self-care for you guys. And I think sometimes people roll their eyes when we talk about, well, you need to engage in some self-care. Self-care is really important. Like, yeah, we know, we know. And when I'm talking about self-care, I mean more than just taking a bath or meditating. It's really about taking care of yourself in every possible sense. So I have this self-care wheel up here because I really think that it gives some helpful suggestions for lots of different areas. And we need to have that balance in our self-care. All of us, I think, benefit from a self-care practice, and it's important to make sure we're not just engaging in self-care in one area. Many of us as caregivers can struggle with prioritizing our own needs. It can just be hard to feel like we have the time and the energy to take care of ourselves. So if that's something that you're struggling with, or if you find yourself struggling with this at some point, I would encourage you to speak to yourself as though you are your loved one. Like, what are some reasons why you might benefit from self-care, or why your self-care might benefit your loved one? Like, if you were talking to your loved one about why they might need to engage in self-care, how might some of those reasons apply to you as well? And caring for yourself on its own is just valuable and important for everybody. It helps us to have our own stable and healthy mental health. Um, this is not the only reason, but it's an important reason for many people. If you are taking care of yourself effectively, it allows you to care for your loved one more effectively. So that whole adage of you can't pour from an empty cup is very true, and we'll see caregivers get burned out all the time when their loved ones are in treatment. And we often will give them homework like, hey, you need to go on a date night with your spouse. You need to go like book a spa appointment. You need to like maybe skip in-person visitation this week because it's really that important for you to take care of yourself right now. Your loved one's not going anywhere. We've got them. You go take care of yourself. Go call a friend on your way home from work today. Anything. Um, so it's really it's next to impossible to effectively practice self-care in every single domain all at the same time, especially when you're caring for someone going through eating disorder treatment. Especially if they're spending any amount of time with you. That's so hard. There's only so many hours in a day. So sometimes those really small things can have a big impact over time. Finding small windows of time every day, pick one or two areas to focus on at a time, can have a big impact, even 5 or 10 minutes a day. And maybe you go and you just lay in child's pose. If you know anything about yoga, you pick a yoga pose and you just hold that pose for 5 minutes, and that's all that you do. You intentionally choose some songs that you really enjoy or that you find soothing or comforting or relatable to listen to in the car on your drive to or from work, or while you're driving around, taking care of your kids or running errands or anything that you're doing. Might be reading a chapter of a book every night before bed, taking a 5 extra minutes to have like a more enjoyable long shower, or just enjoying what it feels like to take a bath or a shower. It can be so many different things, and you guys know yourselves best. And if you aren't already seeing a therapist, definitely would encourage you guys to see therapists. Try it out. That can help guide you for self-care as well. Even if you've never been in therapy, you don't have your own mental health struggles outside of caring for your loved one, it can be really helpful to have someone who's open and validating and non-judgmental and compassionate and can kind of hold space for that, so you can process through your own emotions and experiences. You don't have to worry about, this is someone that I'm going to see every day in my life, so if I talk to them about how I'm having a really hard day right now, they're going to remind me of this next week when I talk to them again, or they're going to remember it and think about me differently. Your therapist is coming in as like kind of a blank slate in a lot of ways. And so it lets you be the focus of attention and caring, even if it's just for an hour every other week. Having that regular therapy is really, really helpful for a lot of people. So I always encourage caregivers to go towards that. All right. Lastly, I just want to go over a few signs of relapse. They're all pretty straightforward, I think. But if your loved one has gotten to a place where your team's saying that they're recovered or they're sort of stable, things that we're looking for if they're going to backslide and kind of have a relapse to some extent or a slip, greater anxiety or irritability around food, maybe pushing back or negotiating food. You're noticing they're looking really anxious when you sit down to eat. Maybe they start to avoid food related situations. So when they're going out with their friends, it's no longer going out to a restaurant. It's no longer having snacks at a movie. It's no longer, baking cookies with them. They're just not doing those things that maybe they had been doing. If you're noticing that that's a big difference or those things start to fall off, that is a red flag. Decreasing volume or variety of intake, one or both, would be a red flag, as well as weight loss for individuals who are prone to being underweight. Or even if you're not, I think any sort of weight loss is potentially a sign that they're restricting their eating in some capacity. Or if they're engaging in other behaviors, we could be starting to see signs of that crossover into a different eating disorder. So that's something else to be on the lookout for. If they become more withdrawn or they start to isolate from you, from their family, friends, other people that they care about, not going to social events anymore, maybe trying to not go to school or go to work. If that becomes a pattern, that would be something to be on the lookout for. Similar to that, missing sessions with the treatment team is a big red flag, as well as not following their schedule or around food, skipping meals and snacks, things like that. A lot of these things are sort of interrelated, but those are really the biggest red flags to be looking out for. And definitely if you're seeing those, talk to your loved one about it, but reach out to their team as well. All right, so that's all that I have for today.